you very much. All right, so over to you, Nora.
Okay. Well, thanks again for inviting me. I'm really excited to be here and to share with you guys something that I'm very enthusiastic about. And this is actually perfect timing. I'm actually on service on our cardiac ECMO team. So I might be referring to one of my patients who's been keeping me on my toes this week. All right. So I am going to begin talking to you guys about delivery room stabilization and resuscitation of neonates with congenital heart disease. I have nothing to disclose. So I don't know how many of you guys have been to Dallas. If you have, you know, everything is big in Dallas. So this is kind of to give you a perspective of what our hospital looks like, where I work. So Parkland Hospital is our main delivery hospital. We have about 15,000 deliveries a year. Last night, the census was actually, it ended up being more than 94. I think it was hitting like 105, 106. We have 110 NICU beds. Children's medical centers where our major surgical NICU is, where our CVICU is. We do neonatal ECMO there, and that's mainly where I work. And we're currently 47 bed unit, hoping to expand soon. So I wanted to start off with a case I had last time I was at Parkland. So my fellow got a call about a baby in the delivery room who's just having some tachypnea. So they brought the baby up, and this is what was on the monitor. So as you can see, not sinus rhythm, uh, definitely tachypnic, thankfully satting okay, and our blood pressure is quite low. We got a chest x-ray and that's what it showed. So people were nervous looking at that rhythm, looking at the x-ray, and kind of very normal response. What do we do? This is not normal. Oh my God, I have no idea. So keep that fear in mind, very normal. And hopefully as we go through this, you guys will, oh, sorry. Let me know if you guys can't see. Can you guys see the movement of my slides?
Yeah, they're moving now, thanks.
Okay, sorry. Um, so this is kind of what my team thought the blood flow will be, kind of squiggling around everywhere, and everybody kind of had a question, what do we do this year? So my goal for this talk is really to talk to you guys about delivery room management, hoping that I can let go of some of that fear. All right, so we are going to begin with a quick review of neonatal transition in newborns with congenital heart disease, and specifically what are the lesions that are at risk for instability, and truly understand, okay, what part of neonatal resuscitation program that we need to modify when it comes to babies with congenital heart disease. So why it's important. A lot of the statistics that I'm going to talk about does tend to be more for the US. I did try to incorporate some international statistics in there. So, at least in the US, every 15 minutes, we have a baby that's born with congenital heart defect. And about 1 in 4 will have critical congenital heart defect. And what we mean by that is those are the lesions that need some sort of intervention fairly early in the neonatal period for um, survival, essentially. What we do know is 50% of patients who have critical congenital heart defect tend to die in the neonatal period. So this is, as you guys can see, an area where we can really make a difference. So if we can figure out why they're dying, work on quality improvement projects to address that, we can really hopefully improve that rate. Now, what are some of the variables that influence mortality? For those of you guys who haven't been to the States, please come and visit us. This is not the temperature map, I promise. This is mainly to just talk about population. There's a lot of variables that do influence mortality. The number one being prenatal diagnosis. When I talk to our fetal cardiologist, it can really vary even with some of our best equipment out there. There's quite a bit of heart defects for lots of reasons that do get missed. One big part of it is also, at least what we're seeing in the States, um, is who is doing the fetal echo. The fetal cardiologists have gone through lots of training, so they know what views to look at. And now, we do have our OBGYN who are doing the quote unquote for review, but they may not necessarily be looking at fine details and unfortunately missing some of these complex heart defects. The other thing that makes a huge difference mortality is timing when they're born, the stabilization, resuscitation, and lastly, the access to higher level of care. So even though we do have, for most of our population, some access to OBGYN, we don't have, high or more access to the higher level of maternal fetal medicine care. And then we have these deserts, like in North and South Dakota, where nobody wants to live because it snows a lot, where we don't even have a cardiac ICU for babies. So, again, those are all the things um, that we do have to consider that impact mortality. And our goal is hopefully to start really improving that and decreasing mortality for our babies. Right. So hopefully everybody in the audience is aware of what needs to happen in order for a fetus to make the transition to neonatal circulation, very successful. So when they're born, they need to have a patent airway. They need to make sure they're breathing spontaneously, all the fluid that's inside their lungs has to be replaced by air. We want to make sure there is blood flow going to the lungs and adequate blood flow going to the lungs, as well as the systemic circulation. Now, in the event where that doesn't happen, that's where a lot of the resuscitation, guidelines, algorithms come in place. I'm not sure how many of you guys are familiar with neonatal resuscitation program, so I'll be referring to that a little bit. But for the main part, when we talk about neonatal resuscitation, whether it's using the AAP NRP program or any other program that's out there, the key components are to really help to improve or maintain thermoregulation, to maintain or promote good respiratory drive, and to make sure the baby's lungs continue to have good FRC and inflate. So the initial steps of positioning, drying, stimulating, providing supplemental oxygen, if need be, CPAP, or in some cases where the drive is not that great, providing positive pressure ventilation, and extreme cases, alternative airways such as intubation or LMAs. Very, very rarely, if you look at in the delivery room, about 10% of births in the US need some kind of help making this transition. Once that is done, with just the initial ventilation corrective steps, less than like 0.1% end up needing chest compressions and epinephrine. That's quite different, about tenfold less than what's in the NICU after the babies are born and older. What's really interesting, and thankfully, most babies with congenital heart defects are actually stable in the delivery room. So, if you are, for example, anticipating a baby to be born with a VSD, if they're having any problems making this transition, very, very less likely that is due to their VSD, more likely that is due to the common things that babies do have issues with: transient tachypnea of newborn, pneumonia, meconium aspiration. So, all the basic foundation of neonatal resuscitation do apply to congenital heart defect, majority of the congenital heart defect babies. However, there are some that need some special consideration, which I'll go into in detail. Now, some of the transition thing we think about that kind of help guide what interventions we're doing is what the oxygen saturation is. There was a study that was done a couple years ago out of CHOP, and it was really nice study. And what they did was they looked at their babies with transposition who, were born in their center, so they actually were able to closely monitor all their vitals. Quite jealous that they were able to do that, and they were looking at what happened to their oxygen saturation with the timing of when they were born. So if you look at the quote unquote target oxygen saturation that we expect for babies when they're 1 minute, 5 minute, 10 minute, they wanted to know for TGAs. As you can see, when a baby with a typical heart, we expect them to range anywhere from 70 to 90%. the transposition grade arteries, I mean, they're really low, like 50 to 70%. And even when we get to the 10-minute mark, you can see a baby with a typical heart, we're getting saturations close to above 90, whereas for transposition, we're mainly in the 70 range. So keeping that in mind, we know we can't 100% follow what we do for typical babies with typical hearts. So even the oxygen, algorithm, we can't necessarily follow that. Unfortunately, at this time, we don't have evidence to make specific detailed guidelines for what to do, what oxygen number to follow for babies with transposition. But there are some, recommendations that we can use for those lesions. Sorry, we just talked about. So what has been done so far when we think of evidence for managing babies with heart defect? What I'm talking about, I should have mentioned, are prenatally diagnosed heart defects. A lot of the studies that have come out are recommendations before NRP Cardiac, that was launched about a month ago, actually came from our fetal cardiology colleagues. And what they have done is taken all the heart lesions and really stratified them based on what lesions are going to need help right away versus those that can wait, a week, 2 weeks, or even down the road. Based on that, they have, stated some delivery room recommendations and what to do immediately after. So, for example, let's take congenital heart defect, who are minimal risk for hemodynamic instability in the delivery room. Those are going to be your ductal dependent lesions, like hypoplastic left heart, critical coarct. Now, for those deliveries, if we know we're expecting that baby, we would want to stabilize everything, make sure we have all the appropriate resources. So perhaps these are the ones where we may actually want to plan an induction, hopefully closer to term. We want to deliver ideally at a hospital where we have, quick access to neonatologists as well as our cardiology colleagues. And in the delivery room, of course, to do routine delivery care, but these are the lesions that are going to need prostaglandins, closely after being born. And if they need to transport to, the place where they might get other intervention like, cath or surgery. Now, for the super serious heart defects, so we absolutely think, 99% these are going to be super sick. So what kind of lesions? We're talking about, transposition who have a very restrictive or intact atrial septum or obstructed TAPVR. And to be honest, any type of Epstein, I don't trust, just like I don't trust any preemie baby. So if I see Epstein, I'm going to put them as my very severe, bucket of heart defects until they prove me wrong. Now, these are lesions where you want to make sure every single resource is there as soon as the baby's born. So these are the ones you're not necessarily going to induce. They're going to be the very scheduled C-section where you ideally want to be at close to term as possible. You may need to have your specialized cardiac team in the delivery room with you or quickly be escorted to where the baby needs to be. A lot of our centers in the States, especially our children's hospital in the last couple of years, have moved towards having delivery rooms in the children's hospital, especially centers with a really high volume fetal center. Currently, we don't have that in Dallas because our delivery hospital's right across the street. What it does is really helps to have that controlled environment. But we do have to recognize that babies with heart defects are going to be born where that resource is not available. So we do need to provide some guidance to the providers taking care of those babies of how do you stabilize them when you don't have a cardiac interventionist right next to you. Um, so I'm just going to quickly go over this real quick. So a lot, and there's been tons of papers on these where they've stratified the congenital heart defects, talk about where should you deliver, when should you deliver, mode of delivery, who should be in the delivery room, Where should they go? Should you start, PGE? When should you consider a balloon septostomy? But there's a huge gap that's missing. And what it is what do you actually do in the delivery room? So if this baby is tachypnic, do you give them oxygen? Do you do CPAP? Do you quickly intubate? What about if it's an undiagnosed heart lesion? And that's where, at least for us, when we think about resuscitation for babies, the two common, you know, I should say, sides of the room is neonatal resuscitation program or pediatric advanced life support. There's always a battle between them. Currently, there are absolutely no guidelines on when to quote unquote transition from NRP to PALS. That's my whole other interest. Um, but regardless of whether you use NRP or PALS, there are huge gaps in both of them. Neither of them really cover cardiac patients. There are other things that they don't cover either, but for, our patient population, it doesn't matter which one you follow. For those specific cardiac babies, it's neither of them are going to cover it. So, where do we go from here? This is just honestly a plug for a seminar. We did an issue in seminars of perinatology. If you are interested in resuscitation, advanced resuscitation, especially in the delivery room of certain babies with anomalies, as well as outside the delivery room. So in the NICU, highly recommend check this issue out. A lot of us worked really hard for it, and I might be biased, but I think it's a great, great reference. The other thing that we have done, this is a paper I wrote with Mary D'Onofrio, one of our main fetal cardiologist expert in this field. And again, we wanted to have some information for our providers into what could be the issue, when can you do NRP, what should you worry about. And we were trying with this paper to really make it concise for our audience so they can quickly pull up, hopefully, this table and know what to do. Again, it doesn't truly fulfill that gap of the steps of NRP. So, based on that, we conducted a study. This actually started uh, back in 2020. If you guys remember, something big happened, COVID. So this was actually the year before COVID. In end of 2019, I was at one of our delivery sites, with my neonatal fellow. We were going through a bunch of deliveries, and for some reason, we had several heart babies being born on the same day. And it was 7 a.m. That's when we have our shift change, and it was a hypoplastic left heart, quote unquote, completely stable, that's going to be delivered. So the baby comes up to our NICU, is on CPAP, needing 100% oxygen. And it was like, well, it's a heart baby, we're fine. Turned out the baby had a whole lot of other issues like undiagnosed CDH and so forth. So clearly, hypoplast was the least of that baby's concern. Um, but for me, what it showed was, um, and I've talked about this with several of my colleagues, is um, the physiology part. I think there is a gap. We're not at the bedside as often as we were 5, 10, 15 years ago. So we kind of go into this tunnel vision. Oh, we know what this is. That's exactly what's going to cause the presentation to be. But that's not always the case. So having that open mind and really think about all the differentials is important. So how are we going to make that happen? Um, Nobody really likes to sit there and listen to 3 hour long lectures. Um, and what I wanted to do for our fellows was also have hands-on active education. So I created these modules and I did kind of like a boot camp with my fellows. We did 4 scenarios. I gave them a case. They didn't know the diagnosis or what to do ahead of time. I let them just run with it. And then we kind of sat down and debriefed and we talked about each of the steps. And as the simulations went on, the lesions got more and more difficult. Um, and they really learned a lot. And when we did that study, I got great feedback. So I was like, great, let me see if some of my Other friends in other places might like it. So that's kind of how the study evolved. And we presented that in 2020 Neo Heart. And from that, we had these amazing, collaborators. And we created this Learn CHD study. The manuscript's coming out soon. Um, and what we did was we created these e-learning modules. We wanted them to be specific for the lesions that are going to be at high risk for instability. We also wanted to make sure that these modules were kind of concise and to the point. And we wanted to make sure that it wasn't just for the physician in the room or just the nurse. We wanted to make it applicable to a wide range of providers, no matter where they worked, whether they worked in the nursery and happened to come across a mom who's delivering a hypoplast versus, our level 4 high level care NICU where you have a fetal, center right there with a delivery room with, state of the art equipment. It took us actually a long time to create these modules to meet all of our goals. When we had them, we wanted to test them out. So what we ended up doing was we piloted first these modules, got some feedback. We also had our fetal expert, a fetal cardiology expert through the Fetal Heart Society, also vet the modules. So just to make sure we weren't saying anything weird or odd or completely wrong. Once we had that, we kind of landed on these four main ones. So we did do a quick recap of fetal to neonatal circulation. Then we had arrhythmia ones, hypoplast, and transposition. We did have other modules that we created, but these are the ones that we ended up testing. We chose these because these are the scary ones that people encounter. And this is where we thought we would get the most out of it, as in these are, the higher learning. So what we were presenting in the modules, we wanted to make sure that the learners got the most of it or from it. So we had nine sites participating, including 32 teams, 102 participants. The team, we try to mimic what's going to be in the delivery room. So provider, whether it's a attending neonatologist, a fellow, or a mid-level provider, are nurses and respiratory therapist. We assigned the team and randomized them. We had an entire randomizing system, not going to go into it. We randomized them to either our modules, so the e-learning modules, or directed readings. What we meant by that, and this is pre, ChatGPT, Grok, or whatever you want to use. We used PubMed for those who remember back then. And we typed in hypoplast, TGA, and kind of looked to see what were some of the papers that kept coming up. So if you were expecting a hypoplast to deliver, and if you just searched on PubMed, what is the resource you're going to most likely go to? So we randomized groups to either getting access to the e-learning modules, or they got links to three like major resources. We gave them about a week or two to go through them. Then before, sorry, we did that. We actually did do a pre-test knowledge survey. And then afterwards, we did a couple of surveys. We did a knowledge post-test. We also did a survey on what did you think of the modules? Would you do them? So acceptability. Then we did 4 simulation scenario. The first one was an abruption just for the team to get used to the environment and to each other. Then we kind of did the true hypoplast, TGA with a restrictive septum and complete heart block. We video recorded them. We did tons of different debriefing as well as, looking at what the teams were doing. So we looked to see whether they did, the NRP checklist. So did they actually followed somewhat of the NRP algorithm? How was the team communication? And did they actually do the critical intervention? So for example, if it's a baby with heart block who is crying but has a heart rate of 60, did the team go straight into doing compressions, or was it a team, that put the leads on the baby, checked for hemodynamic stability, etc. This is just a quick sample, and please let me know if I'm running out of time at any point. Um, for example, our DTGA module, we did a quick overview what DTGA is, like a quick, physiology, make sure everybody was aware. Then we talked about specifically for this lesion, what are the risk factors that would make you concerned? Because not every DTGA is going to be sick. There is a variation, although DTG is another one you shouldn't trust. Um, but there are some that are going to be a lot sicker than others. So, what are those factors? And then when we go into delivery room, there are these key questions that we always ask: gestational age, how many babies, etc. But there should also be specific questions for when we're going to a delivery of a heart baby. And we kind of talked about it in our modules, what to ask. And then what about if we don't know that this was truly a baby with a heart defect? What are some clues that would make you think to consider heart defect? And then what are the specific key managements? These modules were about 15 to 20 minutes because we also didn't want to bore people. And again, we were trying to be very concise with them. So this is the eighth edition of Neonatal Resuscitation Program. Um, so these are kind of areas in the yellow boxes where we specifically kind of had some guidance, I have to use my words carefully, um, or recommendations on where you could kind of fit some of specific things for heart babies. So what I mean by that is the pre-birth questions. For cardiac babies, we want to know what type of lesions. Are there any other anomalies? And the important one, what should be our SAT goals? So if you remember, I talked to you guys about the TGA study where they looked at what should be the typical or most common oxygen saturations. Is that what we anticipate for a TGA? Or do we expect them magically to have SATs of 100%? This really helps having that goal in mind for the entire team because then there isn't that reluctancy to not give oxygen or give too much oxygen. And it also helps the communication um, move along. Same thing in terms of can we use the early stabilization steps? So let's say you have uh, a baby with tetralogy of Fallot with absent pulmonary valve. Clearly, if they're in respiratory distress, CPAP may not necessarily be the way you want to do, or keep stimming them, drying them may not necessarily work. These babies may need to be prone, you know, they may sometimes need more help than just CPAP. So trying to know what um, uh, you know, typical or normal NRP guidance you can follow and where can you make some of those changes for the lesions can also help the team be a little bit more comfortable in the delivery room. And we kind of talked about the target goal saturations and then contingency plan. I think that's something we spent a lot of time on. Um, Again, because contingency plan at my institution is going to look very different from your institution. So we had to be mindful to make it general enough that it would go and be applicable at all major sites, but also be helpful for that lesion. And I'll go into what I mean by that. So again, just to kind of go through the TGA, in the pre-brief questions, the one thing you want to make sure of or think about is the atrial septum. That's going to be a huge clue of whether or not these babies are going to be stable or unstable, whether it's restricted or not. Just a quick thing, just like a preemie, TGA, or pretty much any heart babies, do not trust the atrial septum. We are horrible at predicting whether it's restricted or small. So again, any TGA, just prepare for the worst and be happy when they do great. What about if you have a TGA with intact septum, right? Or if they're restricted? If they are, again, these babies are not going to be the ones you're going to dry, warm, dry, stimulate, see what happens, right? These are going to be the ones that are sick. So you quickly want to move towards stabilizing that airway. Um, what about their saturation? So let's say they are doing okay. When should you give them oxygen? We had a hard time trying to figure that out. And when I talk about NRP cardiac, I'll kind of briefly mention it. In our study, we said, think about if the saturations are not improving after 5 minutes of life and you've done those interventions and the sats are still 75%, not increasing despite oxygen, then we start thinking about, okay, we need to move forward, with advanced airway. Um, this, again, briefly, I don't know why I just went forward, um, talks about what some of the results we found. So when we did our study, interestingly, there wasn't much difference that we found between the article and the modules group if you look at certain lesions, certain heart defect. What was interesting was um, in both groups, those that got the articles and those that actually went through the modules, where, for example, for heart block, we talked about when to use isoproterenol, when to use epinephrine if you don't have ISO, um, or when to just leave the heart baby alone. Regardless, whether our groups did the articles or modules, 50% of them didn't get that intervention right. And what I thought was interesting was 20% went straight for chest compressions, um, even though the baby was crying with a heart rate of 60. Similar with our hypoplastic left heart, some of our critical step like PGE, stat goals, etc. There wasn't much difference between the article group that got the article or the modules. So, what about the knowledge? So, not surprisingly, when you get some information, of course, your knowledge increases. What we found that was really, really interesting was the respiratory therapist group, the nursing group, because that's where we made a huge difference in their pre and post knowledge test. So if you look at the x-axis where it says RT, the respiratory therapist, and the one in the light pink is what was their pre-test for the module group, and then the dark pink maroon color is the respiratory therapist group post-test after they got the modules. And you can see that was like a pretty significant, improvement. So I mean, that made us happy. To us, that showed that one of our objective of making sure our modules, were um, effective and user friendly for all disciplines. It did somewhat prove that objective. Now, even though we didn't find the difference we were looking for, we were kind of bummed about it. But what really made us feel better, what was really exciting about our study was the acceptability part. The fact that pretty much even the group that got randomized to the articles, as soon as the study was over, they wanted the modules. So they really enjoyed having it. They thought it was concise. They thought the concepts that were covered were great. That it was definitely more effective for heart babies than just traditional delivery room management. And what was really exciting is that they will continue to use that education. So that's great. We were high-fiving each other. But again, keep in mind that was just for 9 sites, right? How can we make a bigger impact? So this kind of takes us back. So now we did this in 2020. By the time we finally got the study rolling, getting the data, it was like 2022. And I went to our national AAP conference. And that was a great idea to share this with the NRP steering committee, which terrified me. Anyways, set up this night's proposal, showed them our data. I'm like, here are the modules, please use them. So they said, sure. They got back to me in 2024 and they said, we love them. Great. We would like to create NRP cardiac. I'm like, awesome. Um, I should actually need to change. It is here, not coming in spring. Um, and what we did with NRP cardiac, and I'm sorry I can't go into all the details, was create what we did similar to what we did in the study. So we have 8 modules in that course. Um, and again, they're very concise modules. The first one is just fetal to neonatal transition. Then we talk about the super high risk. We go over the pathophysiology very briefly for each of the lesions. Then we talk about what are the risk factors that will make them stable versus unstable. Then we kind of go through the algorithm. So, what are the pre-brief questions to think about if you have a TGA versus if you have a hypoplast? When do you follow the NRP algorithm? When should you not? And then what do you do if you have a hypoplast that's sick and it's just not responding to traditional NRP? Um, Again, we don't have any evidence. So this was all expert opinion consensus. And what we said was, we know these babies are going to be sick. And what we need to do is decrease their metabolic demand and get them safely to a place where help can be done. Um, so for us, that means intubate, sedate, paralyze. Again, I don't know how it is where you guys are. Uh, Even in the States, those three words, depending on which center you work at, can have a different response. So where I did my training, everybody was totally fine with that. Um, where I'm currently at, I get looks when I say we need to intubate it in the delivery room because that's not where we are doing. Um, so again, these are just general recommendations we made. It's not like must do. Um, so again, I'm sorry I can't give you guys a preview of it. Um, the other thing we did in the NRP cardiac course is we created these videos. We looked through what's available online. There's some great material that's out there, but we really wanted to make these videos very applicable in the delivery room. So they're short videos. I think the longest one, maybe a minute and a half, too. And we really talk about the blood flow, fetal circulation for that lesion immediately after birth, smooth transition, what we expect, and what happens when it's not going to be smooth transition. And the feedback we've gotten, people really appreciated that visualization. So again, I hope that you guys have a chance to, check out the NRP cardiac. All right. I think I've talked too much. So I will pause here and see if you guys have any questions or anything I can answer.
Thank you so much, Nora. One, everybody have to realize Nora thought it was tomorrow, this talk, so I grabbed her from wherever she was. And look at this, all presented and well
Okay.
within time.
Well,
You
I
know,
do have to tell you, so like I said, I'm on service, and this was a very timely day because I have a baby with a very complex heart defect right now in our NICU, which we typically don't. It's just a special day. And that baby actually ended up coding twice. And again, we couldn't follow NRP or PALS. So it was great to think about the physiology and what to do. We did not do the delivery room things, but again, um, it, it's exciting, but it's also nerve-wracking. So having some guidelines, some information is helpful in those scary moments.
Yeah, look, and this is what you did on this presentation. You took us through that NLP and showed us that even that one in the panels had lots of gaps, which in neonatal resuscitation to all the participants here can be very challenging. You showed some examples of known congenital heart disease and the questions we should ask, which I thought was really great. And then, 5 years in the making, but absolutely great, a teaching strategy targeted towards what we do now, visual information, short as a burst to prepare us for whatever is coming. And, this can be applied to congenital heart disease, as Nora has shown. And I guess it can be applied to any kind of rarer kind of disease we can encounter. So that is absolutely good to update yourself before